The hormones that are central to the pathogenesis of diabetic ketoacidosis are listed in this slide. They include insulin, glucagon, and the stress hormone, namely epinephrine, cortisol, growth hormone, and of course, central to the pathogenesis of diabetic ketoacidosis is the free fatty acid. As you are aware, insulin is an anabolic hormone that is responsible for regulating plasma glucose by stimulating glucose uptake in muscle and fat and by inhibiting hepatic glucose production. While glucagon works opposite to insulin in that it protects the patient from hypoglycemia by increasing hepatic glucose protection. Depicted in the slides, insulin, glucagon, and counter-regulatory hormones are central in the pathogenesis of diabetic ketoacidosis. Insulin deficiency can be absolute or relative. This deficiency affects three major organs in the body, namely the fat cells, the liver, and the muscle. And while you want glucagon levels to be low in such situation, in fact, it is excessive. This exacerbates the hyperglycemia due to insulin deficiency. The other counter-regulatory hormones are also out of control due to the feeling of cells of glucose deficiency. This diagram depicts what happens in the fat cell. With insulin deficiency, the fat cell goes into lipolysis. And the reason this happens is because of the activity of the enzyme lipoprotein lipase. This enzyme is easily inhibited by a small amount of insulin. And as such, deficiency allows this enzyme to perform lipolysis in the fat cells. Therefore, fat is converted into free fatty acid, and free fatty acids are transported to the liver where it is converted into ketone bodies. As I have mentioned earlier, the liver is a major organ and responsible for the pathogenesis of diabetic ketoacidosis. Since glucagon levels are excessive, when it enters the liver, it makes the liver a sugar and keto acid factory by stimulating glycogenolysis and gluconeogenesis. This is an opposite action to insulin action, which is glycogenesis, glycolysis, and lipogenesis. The kidney is a major organ in the body, and it is very important in the pathogenesis of DKA. Serum glucose above 300 causes osmotic diuresis, and with it, it pulls salt and water. This causes dehydration and electrolytes abnormalities. Keto acids as well act as non-absorbable ions in the distal tubules and are secreted as sodium and potassium salts, hence contributing to the deficiency of total body potassium and sodium. The skeletal muscle, which is a major organ for the action of insulin, in skeletal muscle, potassium moves outside of the cell. Despite severe total body depletion of potassium, which is estimated to be about 300 to 600 millimole, potassium levels are frequently normal or frankly elevated. There are several mechanisms responsible for this. One of them is that potassium leaves cell with water, and it leaves in the extracellular fluid compartment, which is hyperosmolar. Potassium leaves out of the cells in exchange for hydrogen ions. And loss of intracellular phosphate also leads to loss of intracellular potassium. Lack of insulin per se allows the potassium to leave outside the cell. And the protein breakdown leads further to potassium leak. All of these leads to total body depletion. And if there is oliguria, which sometimes is present in severe volume depletion, that leads to decreased potassium excretion and at times leads to potassium elevation in the plasma. So to recap the pathophysiology of DKA, this diagram summarizes all the pathophysiological steps responsible for diabetic ketoacidosis. Absolute insulin deficiency causes lipolysis. That causes free fatty acid to enter the liver. These become converted to ketone bodies, and that reduces the pH in the plasma. The counter-regulatory hormones are excessive. That leads to proteolysis and decreased protein synthesis. All of these leads to gluconeogenesis with further elevation of hyperglycemia. Relative insulin deficiency in HHK, that is hyperglycemic hypersmolar state, leads to hyperglycemia and fluid depletion. But because there is some insulin available that inhibits lipoprotein lipase, and therefore ketone synthesis is minimal.